I'm Adam Szulewski. I'm an emergency doctor here at Queen's. And I'm also cross-appointed to the Department of Psychology. I have a role in postgrad as the educational scholarship lead, and I'm the program director of the resuscitation and reanimation program through our Department of Emergency Medicine.
My name is Stephen Brooks. I'm an emergency physician at Kingston Health Sciences Center and a professor in the departments of emergency medicine and public health sciences at Queen's University.
Before we get into the details of the project itself, I think it's important to consider a little bit about the background of the project. So we've known for years that the data that we input into our medical record around resuscitation cases is really not very good. And so it's hard to do research and to learn about what actually goes on because the data that goes in is just of such poor quality. And let me give you an example. I could be in a resuscitation case for 45 minutes, sometimes more than an hour. There's lots of things going on, as you can imagine. There's lots of medications being given, lots of instructions being given, and lots of procedures that are happening simultaneously. There's a big group of people in that room. There's a group of nurses, often multiple doctors, respiratory therapists, all working toward a common goal. I'll come out of the room and it's a busy shift, and I'll get on the computer and I'll write 2 paragraphs about what happened. And the truth is, that really doesn't do a good job encompassing all the things that happened in that room. Sure, we do have records of times when medications were given. We have the nurses' records as well, but there really isn't a comprehensive part of the chart where we can really glean key metrics about care. And so if we think about trying to improve our care as individuals, as groups, as departments, as society for patients who are in need of resuscitation, we need better data. And one of the ways to do this is to look at video capture. And I wish I could tell you this was my idea from the beginning, but it's not. This is actually something that's been done around the world for a couple of decades. And in particular, in Edinburgh in Scotland, they had developed a system a number of years ago where they would videotape resuscitations that were done in their department in order to improve the quality of care that was given later on. And Steve, who will speak in a second, was in Edinburgh doing a sabbatical. And I had the honor to come visit him and his team there, learned about how the system worked there. And then after lots of effort and going through the right channels and making sure things were done right and thoughtfully, considering all the issues around confidentiality and privacy, we made it happen in Kingston. And then a new research idea came out of that. And I'll hand it over to Steve.
This project is really at the core about improving the quality of our resuscitations in the emergency department. And using data from the chart is always an incomplete picture of what's going on in the resuscitation bay. For many years, we've been looking at things like the quality of the CPR as measured by feedback devices on defibrillator technology that we use on patients. We've been looking at the notes of nurses and doctors in the chart, and that really has not allowed us to see the whole picture of what's happening in a resuscitation bay. So this project is about implementing a new data source, which is video and audio recording of resuscitations in the emergency department. And with that kind of new data stream, we can see all sorts of other aspects of the resuscitation that are simply not recorded in the patient's chart. Things like team dynamics, leadership styles. We can look at the reasons behind certain things happening that are documented in the chart, but we don't have the reason why. And so this rich new source of data allows us to answer questions that we have not been able to answer in the past with data from the chart. So that's what makes this project really innovative. And thanks to the amazing efforts of Adam and the team at Kingston General, we were able to implement the video and audio recording in a way that respects patient privacy, in a way that respects the healthcare providers who are being recorded on the video, and it allows us to really get into a whole new realm of understanding what happens during resuscitation and aiming to make our resuscitations more successful in helping our patients. I think in the first instance, we're going to be able to view these resuscitations and line up what we see on the video with the data that we collect in the chart, and aligning that with what actually happens to the patient in the resuscitation bay, and ultimately their outcomes with respect to how they do after the resuscitation, whether they live or die, and other important outcomes for them. So we're going to be able to look at these videos and then understand about team dynamics, provider positioning in the room. We're going to be able to look into reasons for perhaps less than optimal CPR quality. We're going to be able to identify procedures that are occurring that are not recorded in the chart with much detail. And we're going to be able to use that information and then essentially answer questions about how those sorts of things impact patient outcomes. And we're also going to be able to ask and answer questions about how to better prepare our teams to provide resuscitation in the emergency department based on this data. One of the first questions we're looking at is trying to understand the causes of pauses in chest compressions, or the reasons for less than optimal CPR being provided for patients who are experiencing cardiac arrest. We know that CPR quality is so critical with respect to the outcomes that patients experience after cardiac arrest, but we are unable to look at that and understand it completely by looking at data that we record in the chart and that traditionally we would look at in cardiac arrest research. So with the video, we're going to be able to see why CPR was paused for too long, or we're going to be able to see why the depth of compressions maybe wasn't optimal. We're going to be able to see the reasons for that with audio and video recording. And that really has not been done in any significant way in the research to date. So this is going to be a real opportunity to answer new questions like that and improve our care.
And I'll build on that. I think the data that will come out of this is incredibly rich. Video data is an order of magnitude more informative than purely quantitative data, because we'll have both, and we'll be able to triangulate some of the findings that we're observing. And cardiac arrest is not something that happens often in any one hospital. And the advantage of what we're trying to do here is trying to collate data from a number of different sites. And one of the next steps with this work, and the plan is to work with some of our colleagues from all over North America who have similar systems in order to create a database where we can have big numbers and where we can actually look at outcomes in meaningful statistical ways, so that we can actually see whether what we're observing has impact on hard patient outcomes. And so that's an exciting next phase of the study that we're all really looking forward to.
SEAMO Innovation Funding is absolutely critical to this type of project. So this is a fairly high risk, really innovative approach to collecting data in resuscitation science. And for us to be able to get some early seed funding to support our methodology and the development of our database here in Kingston is absolutely critical to the long-term success of the project. I've been the beneficiary of innovation funds in the past, and I can tell you that those funds have had such a profound impact on the projects that it has funded. And on numerous occasions, I've been able to use the results of the Innovation Fund projects to then go after larger grants to support expansion of the programs outside of Kingston and Queens, to engage with other sites and undertake definitive studies on the foundation built by the Innovation Fund. So this would be very difficult for a project like this to take a first step and go and get tri-agency funding from larger funding organizations in a very highly competitive environment where failure is more common than success. So to be able to get some early funding for us to prove feasibility and get some preliminary data, and certainly from this project we will be able to determine some important initial outcomes, but most importantly, the funding allows us to use this as a springboard and go after larger grants that support the project expanding to other sites and allow us to answer more other important clinical questions. So an absolute critical source of early funding to take great ideas like this and make them successful and increase their impact on patient outcome and improving care for patients who need resuscitation in our emergency rooms.
And the other thing I'll mention is I was also fortunate enough to receive a SEAMO Innovation grant when I first started on staff, and that would have been in 2015. So I can tell you from experience that did make a big impact on the early part of my career in order to jumpstart a number of projects. And the other thing that it allows us to do, it allows us to provide opportunities for our learners, our residents, and our medical students who want to be involved in this type of work. And provide some infrastructure there that might not otherwise exist. And so I think not only does this help drive innovation for patient care, I think it also provides a huge opportunity for our learners so they can build their own research careers and then take off from where we've stopped, later on.
Well, I just wanted to say that this project would not have been possible with the incredible work from Adam, to lay the groundwork. It took some courage to do this. After seeing something in Edinburgh, it's a big deal to come back here and make a proposal that, on initially considering this proposal, taking video cameras and video and audio recording patients and healthcare providers in the resuscitation bay, as you can imagine, that created some challenges with respect to protection of patient privacy and again, protection of the provider's privacy as well, and addressing concerns around this type of data collection. And I would say that Adam did this masterfully and built a program and infrastructure and a governance system that allows us to do this safely and allows us to do it within the confines of PHIPAA, privacy legislation, and does it in a way that all members of the emergency team and the hospital administration are comfortable and supportive. And that takes a lot of negotiation and careful planning and systems development. So just from my point of view, the research work that is being facilitated here really came from years of work and amazing skills in developing a team that we've seen from Adam, and I just wanted to make sure he gets recognized for that work.
Steve, you're as usual too kind. While I will point out Steve was part of that team and was a huge mentor and made it all happen, along with a number of other players who really supported this work. We're excited that we're here. We were set back by the pandemic. We got all this up and running, and then there was a lot of excitement around moving a project like this forward. And then, of course, priorities had to change, because of the situation that we were all in. And now, as we're emerging on the other side of this pandemic, thankfully, we now have the energy, the human resources, and now funding from SEAMO to make this sort of thing happen. So I think this is the beginning. I think this is, big project number one, but this is some infrastructure that we hope that others will build on and will, outlive, Steve and I. This is for the greater good, hopefully, and we hope that other people join and see the opportunity. And so maybe a little plug that if there are other departments or individual docs or others in our ecosystem who feel like there might be a role for them to get involved either with this specific work or with related work with the infrastructure that's been developed, we highly encourage them to reach out, and we'd love to work with you.